Hello dear students, welcome back to my YouTube channel Physiology Learning. In today's video, we are going to continue with our gastrointestinal physiology. We are discussing the gastrointestinal physiology almost the last few videos. So we are discussing the part 3, and in this video, I am going to discuss about the gastric and pancreatic function test. In the next video, I will be discussing about the liver function test. So without further ado, let's get into the topic. So first is gastric function test. All of us know the most important gastric function is to produce acid. So that could be tested. So test for gastric acid output is basal acid output we can check, or maximal acid output, or a peak acid output we can check. And many times nowadays we have more advanced techniques also, wherein we are not going to test the gastric function, but we can look at the gastric epithelium like upper GI endoscopy and so many other tests. So but here we are going to specifically discuss about a function test. And there are a group of other tests also. One is called as the Hollander insulin test, and we can measure the levels of serum gastrin and pepsinogen levels. And there is something called urea breath test. So first we are going to discuss about the gastric acid output test, the basal gastric acid output. So this will help us to determine at which rate it is secreting without any stimulation. That's why we are saying it as basal, because it is the secretion at the basal levels. For this, the subject has to do an overnight fasting, and after that, with the help of a nasogastric tube, the gastric juices will be collected, and this process will be spread over a time period of from 9 a.m. to 9 p.m. So we will collect it through the entire day without any stimulation, and the normal value is usually collected is around 400 ml, and the concentration is around less than 10 millimole per hour. So this will be the concentration, and generally these levels of gastric acid secretion, the basal levels, are about 0 to 40% of the peak acid output. So we'll discuss what is peak acid output, but it should be that much levels only. But in a patient, if the basal secretion is really high, we have already discussed some of the syndromes in previous videos. So if it is going beyond 60%, that is the basal output is beyond 60% of peak acid output, it means this patient is having excessive secretion of gastric acid, and this can happen in a tumor which is called as gastrinoma, and you guys might be knowing by this time it is also called as Zollinger-Ellison syndrome. Zollinger-Ellison syndrome. So all the syndrome and what is gastrinoma we have discussed in the previous videos. And next, going on to the maximal acid output. So in basal condition we did not give any stimulation. Here we are going to give stimulus. What is the stimulus? It is nothing but the gastrin in a different form, that is pentagastrin or histamine. And we know that gastrin, histamine and acetylcholine, all of them are huge stimulants of the gastric acid. So here we are going to test with some stimulus. And here the acid output will be measured for every 15 minutes. So that will be about 4 measurements over the period of 1 hour. And this is normally around less than 50 millimoles per hour. So suppose for example, this is reading number 1 and this is reading number 2 and reading number 3 and reading number 4. So here we'll measure all of them and then find out what is the secretion over this period of 1 hour. And what is peak acid output is, in peak acid output also we'll measure it in every 15 minutes, but we will check 2 consecutive higher values and then we'll multiply it by 2. So it is also like over the period of 1 hour. But this is testing for the peak acid outputs. So 2 highest consecutive peak into the 2. And generally the peak acid output will be obviously more than the maximal acid output. And the basal acid output should be less than 40% of this peak acid output. So these are the tests where we are directly testing the gastric acid output. Then coming to the other test, this Hollander test is one of the historical tests, but it is interesting to learn it. What happens when you give a patient with insulin? That it will cause hypoglycemia, and this hypoglycemia will stimulate the vagus and then increase the gastric acid secretion. So this is the normal phenomenon. So this I will write it as if this is the normal phenomenon. But what happens in these patients? Generally, previously, before the invent of the PPIs, the proton pump inhibitors, for gastric acid secretion, to suppress it, the surgeons were doing vagotomy. They are going to cut the vagus and then reduce the gastric acid secretion. Suppose if you do a vagotomy in this patient, what is going to happen? Even though if I give insulin, the gastric acid should not be produced. So post vagotomy, even if I inject insulin, because vagus should be there to produce the gastric acid. So the gastric acid increase should not be there. To test the completeness of the surgery, they will do this Hollander insulin test. Suppose a surgeon has done the vagotomy and after that he is giving insulin. If the gastric acid is still produced, it means that the surgery is not completed properly. So this will help them to test the completeness of vagotomy. So post vagotomy, this can be done to check for completeness of surgery. Okay. Next, coming to the other test, we can directly measure the serum gastrin levels, or we can measure the serum pepsinogen levels also, because they are produced from the gastric stomach only. And the gastrin level should be less than 100 picogram per ml, whereas the pepsinogen level should be less than 160 picogram per ml. And there is another test called as urea breath test. So all of us know the bacteria H. pylori is going to produce the enzyme urease, which can cleave and cause the production of urea. And in these patients, whenever the breath is tested for urea, it will be positive. So a positive urea breath test, it is not actually gastric function test, it is an indicator of this H. pylori infection. So this is also can be done. So these are the tests for gastric acid secretion, which are called gastric function test. Now moving on to the pancreatic function test. The pancreas has two different functions. One is the exocrine secretions, so exocrine function, and endocrine functions. In exocrine function, there are two different types of tests. One is called direct test, where you are directly going to estimate the enzymes, bicarbonate, and all other levels directly. And there is something called indirect test also, wherein we are going to assess for the byproducts. So coming to the analysis of pancreatic juice. So pancreas, I have already briefly discussed the GI hormones in the previous videos, where I said that whenever we give secretin is going to increase the bicarbonate levels of the pancreatic juice, and CCK will increase the enzymes of the pancreas. So when you stimulate by secretin, if the bicarbonate output is less even after stimulation by secretin, it means this patient might have chronic pancreatitis. In chronic pancreatitis, the secretion will be reduced. And CCK stimulation, it is to check for the enzyme secretion. Or you can give a test meal also. There will be a standardized meal with certain proportions of carbohydrates, proteins, and fats, wherein you give the test and assess for the levels of pancreatic juices for bicarbonate and enzymes. So that is a test meal test. So these are direct tests where we are directly assessing the levels of enzymes and bioactives. Coming to the indirect test. So in our previous discussion of digestion and absorption also, we saw most of the important enzymes for fat digestion, carbohydrate digestion, all those digestion, protein digestion, all of them are produced by the pancreas. So we can do a stool examination, and if undigested material is found in the stools, it means that the pancreas has not secreted properly. So undigested fibers and fats can be checked, and generally this fat level should be less than 7% of intake. And if you give a known amount of fat and do the stool examination, if it is less than 7%, it means that pancreas is functioning properly. If it is more than 7%, it means that the pancreatic enzymes are not actively secreted. Then there is something called fecal elastase 1. This elastase 1 is actually produced by the pancreas, and if it is low, it means that the pancreatic secretions are not coming adequately. So it indicates pancreatic insufficiency. Next, students who are watching in first year, whenever you go to step onto your clinical postings, in all pancreatitis patient, you will find these two tests. One is the serum amylase and serum lipase. Both of them are produced by the pancreas. And in acute pancreatitis, what will happen? Their levels are extremely raised. And this lipase is a more sensitive indicator. Among both are important indicators, amylase and lipase, but this lipase is a more sensitive indicator. And now coming to one of the older tests, I would say, wherein it is called trioline breath test. What is this trioline? This trioline is nothing but a triglyceride. This trioline is nothing but a radio labeled triglyceride. So it is nothing but a flat. And we know that pancreas is lipase is involved in the fat digestion. So lipase is going to act on this. So when it is acting on this triglyceride or trioline, what is going to happen? It will produce CO2. If adequate amount of CO2 is produced, it means this patient is having good amount of lipase. So less CO2 indicates the fat metabolism is malabsorption or maldigestion is happening in this particular patient. Then coming to another one historical test wherein they used to find the efficiency of trypsin, we can say. So this test is called as dual label Schilling test. So I am going to use two differently labeled vitamin B12. One is the 57 labeled one, that is cobalamin, and another one is 58 labeled cobalamin. So in a normal patient, this 57 cobalamin is combined with intrinsic factor, and this 58 is combined with R binder. So this R binder also I have discussed in vitamin B12 reabsorption. So in a normal patient, if you give this, what is going to happen? Both the materials, like intrinsic factor combined one as well as the R binder combined one, both of them will be normally absorbed and then excreted in the equal amounts in the urine. So in a normal patient, both these forms can be reabsorbed. But in a patient who is having trypsin deficiency, what this trypsin has to do is, this trypsin has to first separate this R binder from the vitamin B12 so that this cobalamin can combine with the intrinsic factor and get reabsorbed. For a combination with intrinsic factor, we don't need any additional factor because this intrinsic factor and cobalamin directly will go into the ileum and they can be reabsorbed. But if it is bound with the R binder, which is from the saliva, so from the saliva it is naturally produced, but here we are giving it in combination. So this R binder has to be kicked off first from the cobalamin so that the intrinsic factor can bind and it can be reabsorbed. If there is a trypsin deficiency, the R binder is not relieved, so this particular cobalamin will not be reabsorbed. So if I find a decrease in reabsorption of this 58 labeled cobalamin, it indicates the patient is having less amount of trypsin. I hope it's clear. Then next, coming to the endocrine functions. Endocrine functions, all of you know, the most important hormone that is produced is insulin. But whenever insulin is produced, it also has the production of equal amount of another substance which is called C-peptide. So I can measure the serum levels of insulin or C-peptide levels also. If we are able to measure the levels of insulin, why we are measuring C-peptide levels in sometimes? Because let's assume a patient is taking exogenous insulin. Exogenous insulin means he is taking insulin shots. Suppose a diabetic patient, he is taking insulin shots. In that patient, if I want to assess how much the pancreas is being produced, I cannot identify because this is also insulin, that is also insulin. In those patients, if I measure the levels of C-peptide levels, it is more or less similar to the endogenous insulin because both of them are produced in equal quantities, because both of them will be a combined molecule and later on it will be cleaved to form a separate molecule. So their quantity is similar. So in those patients, I will measure the C-peptide levels in a patient who is taking exogenous insulin. Then I can do the blood glucose simple test, which is a estimate, or we can say the efficiency of insulin can be tested easily by a blood test, blood glucose levels. The one is fasting, I can do postprandial and HbA1c. So these are the test, function test. But again, for GAT, we have so many other investigations. For the pancreas also, we have other investigations wherein you can look at the pancreas or do scanning test also. So this is all about the gastric and pancreatic function test. In the next video, we are going to discuss about the liver function test. Thank you for watching the video. If you have any further doubts, kindly drop it in the comment section. I'll be happy to make a new video on it. Thank you so much.